Hello, everyone. My name is Miriam Altina, Medical Affairs Dietitian at VitaFlow International, and I'm very happy to welcome you to today's webinar hosted by VitaFlow titled Challenging Cases in Young Children with PKU, Sharing Experiences Using GMP. This webinar aims to support healthcare professional education with regards to the dietary management of children with PKU. A few housekeeping items before we get started. The webinar is intended for healthcare professionals only. The webinar will last 60 minutes and will include time for questions at the end. If you would like to ask a question, please use the question feature on your screen. All questions will be screened and select number will be answered by the speakers at the end. The webinar is being recorded and will be available on VitaFlow's website for healthcare professionals education VIA in a few weeks' time. A PDF of the presentation slides are attached to your screen for download. A feedback form link will be sent to you via email after the webinar. Financial support for this presentation was provided by VitaFlow International, a Nestle Health Science company. The views expressed herein are those of the presenters and do not necessarily represent VitaFlow's views. The material herein is accurate as of the day it was presented and is for educational purposes only and not intended as a substitute for medical advice. The learning objectives are listed here on the screen for you. Without further delay, it is my pleasure to introduce our first speaker for today's presentation, Chanel Suarez. Chanel Suarez is a senior genetic metabolic dietitian and has worked as a clinical metabolic dietitian at the University of California, Los Angeles in the Division of Clinical Genetics since 2016. She has had the opportunity to present on the topic of inborn errors of metabolism at several professional meetings and conferences, as well as frequently serving on advisory boards related to inborn errors of metabolism. Chanel currently serves on the board of the Genetic Metabolic Dietitian International, GMDI, as co-chair of the Ad Hoc Committee on Mentorship. I'll now pass to Chanel to get us started with an overview of GMP, followed by a case study.
Thank you so much, Miriam, for the very kind introduction, and thank you to VitaFlow for inviting me to speak today. We're going to go ahead and get started with an overview of GMP. I first want to walk us through the history of protein substitutes in PKU, really highlighting those major milestones that led up to the development of GMP. So in 1952, the very first protein substitute for PKU was designed and produced in a laboratory in the UK. And to put it very simply, casein was hydrolyzed, then filtered to produce a clear solution of amino acids, which included phenylalanine. This was then removed by a second filtration method. The production of these first formulas was challenging and time-consuming, and it was reported that they were really quite unpalatable. An interesting fun fact is that for infants, the powder was mixed with sugar, wheat starch, double cream, and water. And for older children, they would often flavor it with tomatoes and give it as a soup. So really an interesting part of the history of protein substitutes. Moving on, in 1954, the production of hydrolyzing casein powder moved from hospital laboratories to more commercial production that then used synthetic filters to separate and purify the hydrolyzed casein. In the 1960s, commercially produced amino acid formulas were then made from pure crystalline amino acids from the fermentation of bacteria. And compared to the hydrolyzed formulas, these had several positive attributes such as improved taste, a lower daily volume requirement, and an easier ability to manipulate amino acid composition. Gradually, over time, more advancements were made to meet the changing nutrition trends, to improve taste, to offer more variety, and also to better accommodate nutrition requirements for different life stages, such as infancy. In the 1980s, the commercially produced protein substitutes were made more nutritionally complete with the addition of things such as carbohydrates, fats, vitamins, and minerals. In the early 2000s, several improvements were made, including the addition of essential fatty acids in protein substitutes for young children, the emergence of a spoonable, low-volume paste that was created for young children to help meet developmental milestones, and then a new way to deliver amino acids in the form of tablets came onto the market. In 2005, a more convenient, ready-to-drink option came onto the scene as well. So this all leads up to the development and use of casein glycomacropeptide powder with added L-amino acids, also known as GMP protein substitutes. GMP was first used in the United States in 2008, and later it was introduced in the UK in 2017. So for this presentation, we're really going to be focusing on the use of GMP in PKU, but I do want to mention that protein substitutes in PKU continue to evolve and expand, and it's really an incredibly exciting time. So what exactly is GMP? Well, GMP is actually a whey-based natural protein that's derived from the cheese-making process that naturally contains only residual amounts of phenylalanine, or Phe. The figure on this slide details the process of creating GMP from the cheese-making process. And while we're not going to spend time today going into the specific details of this process, I do highly encourage you to look into it when you have a few minutes because it's really pretty cool. Now diving just a little bit deeper into using GMP as a protein substitute for PKU. So overall, GMP-based protein substitutes are whole protein alternatives to synthetic amino acid-based protein substitutes for individuals with PKU. Essentially, unmodified GMP is purified to reduce residual Phe content, within the estimated residual Phe in GMP being about 1.8 milligrams of Phe per 1 gram of protein equivalent. Then, as you can see in the figure on this slide, the purified GMP is supplemented with indispensable free amino acids, micronutrients, and DHA to make a more nutritionally suitable protein substitute for PKU. Let's now talk about some of the potential benefits of a GMP protein substitute. Well, when we look at those consuming amino acid protein substitutes in comparison to GMP protein substitutes, we see quite a few. To start, better taste and texture is reported. Since GMP protein substitutes are made from a whole protein source, they tend to be more palatable, leading to improved acceptability and a higher frequency of intake, which, as a metabolic dietitian, I love. There is also reportedly less GI upset, so things like nausea, diarrhea, constipation, heartburn, and abdominal pain. Again, fewer GI side effects can lead to improved acceptability and higher frequency of intake, which is a total win. Next, often individuals report with GMP protein substitutes improved satiety, so less feelings of hunger and more fullness. And there's more. Additionally, improved protein synthesis has been found with utilization of GMP protein substitutes, as there's greater nitrogen retention to better build up protein stores. Next, improved Phe utilization. So there's a slower absorption of amino acids from a whole protein source in comparison to those comprised of free amino acids only. In fact, less variation in plasma Phe concentrations were found when fasted and postprandial plasma was compared. Finally, and we're going to go into this in greater detail shortly, but a trend towards improved growth and body composition in children was observed in those consuming only GMP as a protein substitute. We're now going to transition into evidence related to the use of GMP protein substitutes in PKU. As I mentioned earlier, there is residual Phe in GMP protein substitutes. So let's discuss this and consider its impact on metabolic control. The first study I'll mention is from Ney and colleagues from 2016. And in a randomized controlled crossover study, subjects consumed their usual low-Phe diet plus either amino acid protein substitutes or GMP protein substitutes for 3 weeks. This study found that plasma Phe levels were not significantly different with either amino acid protein substitutes compared to GMP protein substitutes. Of note, they found that subjects in the GMP protein substitute group consumed an extra about 88 milligrams of Phe per day from GMP protein substitutes, and despite this increase in Phe intake, a significant increase in plasma Phe levels was not found. Now, in comparison, there was a study conducted by Daly and colleagues in 2019, in which my co-speaker today, Anita, was involved with. And this was a longitudinal parallel controlled study in which 29 subjects were given GMP protein substitutes and 19 consumed their usual amino acid protein substitute. The GMP protein substitute gradually replaced amino acid protein substitute only as long as plasma Phe levels were maintained in the target range. And what this study found is that plasma Phe levels, while maintained in target treatment range throughout the study, did in fact increase significantly in the GMP protein substitute subjects. So 48% of subjects were able to completely use GMP protein substitutes, but on average, subjects could take about 75% of their daily protein substitute requirements from GMP protein substitutes without affecting their metabolic control. So now switching gears a little bit, what are some of the findings on the long-term efficacy of GMP protein substitutes? Well, Daly and colleagues, again, including my co-speaker today, Anita, published 2 papers in 2021 looking at more of the long-term outcomes of utilizing GMP protein substitutes. These papers were based off a 3-year-long prospective longitudinal parallel controlled study that included 19 subjects who took amino acid protein substitutes only, 16 subjects who took both GMP and amino acid-based protein substitutes, and 13 subjects who took GMP protein substitutes only. In terms of growth and body composition, looking at factors such as height, lean body mass, fat mass, and percent body fat, there was a trend towards improved growth and body composition in children consuming GMP protein substitutes exclusively when compared to those taking only amino acid protein substitutes or a combination of both. In terms of bone status, using measures such as a DEXA scan, blood and urine bone turnover markers, also blood biochemistry, all subjects in good metabolic control were found to have bone density in the normal reference range. So this study really revealed that the long-term consumption of GMP protein substitutes and amino acid protein substitutes can both support normal bone growth. Now, considering the evidence that we just reviewed together, it really leads us up to this point, which is to consider the introduction of GMP protein substitutes in individuals with a very personalized approach. Let's first think about individuals in which the potential impact of Phe in a GMP protein substitute would be less likely to have an effect on plasma Phe. So we think of those individuals, for instance, with mild mutations who already tolerate a moderate to high dietary Phe intake. We also tend to think of those who take the cofactor tetrahydrobiopterin. We also think about those who have historically had a poor adherence to taking protein substitutes and are really looking for something that they're willing and able to take. And then those also who have been off diet for some time and are really looking to come back to diet to manage their PKU. So when we consider the introduction of GMP protein substitutes, we can kind of think of it as a 1, 2, 3 suggested approach. First, you'll want to provide GMP protein substitute education to the individual with PKU or the caregiver, and you're going to want to get a baseline Phe level. Next, you're going to want to tailor the introduction of the GMP protein substitute off of that individual's history and or their own personal preference. And then thirdly, you're going to want to, of course, monitor those plasma Phe levels throughout this transition and throughout this introduction of the GMP protein substitute. So again, this is going to be super individualized, and you can aim for either this gradual transition from amino acid protein substitutes, where you gradually, one by one, replace GMP protein substitutes for amino acid-based substitutes as tolerated with this frequent Phe level monitoring. On the flip side, in some individuals, you may be really comfortable with making more of a full switch to GMP protein substitutes without following such a systematic introduction. So again, very individualized approach, listening to your individual with PKU, the caregivers, and then also what you're comfortable with as a metabolic dietitian as their provider. So on the other hand, you may actually really want to consider the potential impact of Phe in GMP protein substitutes on those plasma Phe levels in another group of individuals with PKU. So different from those that we mentioned in the previous slide, you'll want to think of its impact in those, for instance, that have more classic mutations and tolerate a lower dietary Phe intake, as we know that the GMP and GMP protein substitutes is more likely then to have an impact on their plasma Phe levels. We also want to think about women who are pregnant and with maternal PKU, really requiring tight blood Phe control. And then, of course, children, again, when very tight blood Phe control is advised as well. So for these types of individuals with PKU, really focusing on more of that gradual, systematic introduction of a GMP protein substitute may be really advantageous to closely monitor and achieve metabolic control. So you're going to likely recall having seen an option to take a survey after registering for this webinar. And so we're going to review the results of that survey now. So the very first question of this survey asked, do you use GMP protein substitutes in children 1 to 5 years of age? And 8 responded yes, 5 responded no, and 2 responded not applicable because they don't see patients in that age group. Based on how you answered the first question, yes or no, you then had a second question. So for those who answered yes, they were asked to elaborate what was the decision driver to use GMP in this age group. And you could choose more than one answer as applicable. So taste of GMP was chosen 8 times. Then potential health benefits of GMP was chosen twice, as was the current evidence available for GMP. Other was selected once and further elaborated on that GMP protein substitutes are used in milder forms of PKU when they develop higher Phe levels as a result of their age-appropriate diet expansion. This slide shows what the current barriers are to using GMP. And for those who responded no in the first survey question, again, you could choose more than one answer as applicable. So not enough calories in current GMP options, age indication, and Phe content of current GMP protein substitute options were chosen once each. And then other was chosen twice and further elaborated on that one survey taker's clinic does not use GMP at this time, and another person doesn't often work with individuals with PKU. So thank you so much to those of you who took the time to complete this survey. I'm now going to go ahead and introduce you to my case study. But before I do want to just share a little bit of my own personal journey with using GMP protein substitutes. So when I first started as a metabolic dietitian, GMP protein substitutes were already on the market. The very first patient I used a GMP protein substitute with was actually a woman with a more mild form of PKU who had been off diet for many years, but during her pregnancies, she required a protein substitute to maintain her metabolic control and to meet her growing needs throughout the pregnancy. So since she really only takes protein substitutes during pregnancy, and she historically just had this really strong distaste for amino acid-based protein substitutes, I really felt like the GMP protein substitute was a great option for her to try given its palatability, and this was very successful. So I started implementing GMP protein substitutes in many of my other patients, like older children or young adults, who just were chronically struggling to take their prescribed amounts of amino acid protein substitutes due to a variety of factors. A lot of times the taste or GI distress or just this difficulty getting satiated and feeling full. And again, as I saw this success with this group of individuals with PKU, I continued to collect these experiences, and I really then had this increased confidence to successfully begin introducing GMP protein substitutes in my younger children with classic PKU, a lot of times complaining of things like stomach aches or just not getting full on their current nutrition routine. So I really was able to implement it with them successfully and see firsthand the positive impact of GMP protein substitutes on these individuals. So this leads me up to my case study today. So at our metabolic clinic, we received a positive newborn screen for a full-term baby girl born at 39 weeks in the United States. We completed confirmatory testing and confirmed diagnosis of PKU. Now, here is a little bit of the plot twist. The parents then report that they have a 7-year-old son who was born in Armenia and has this global developmental delay in multiple therapies. He received a diagnosis of autism at 3 years old. He has much lighter hair than all of his other siblings and this very pale colored skin, sensitive to sun, and some skin issues like eczema. So I think you all know where we're going with this. So it turns out this boy was in fact previously evaluated by clinical genetics, and an autism and intellectual disability panel was recommended. But the family did not complete the recommended testing before traveling back to Armenia. So once we heard about the concerning clinical picture of the boy and given his sister's new diagnosis of PKU, we drew a plasma Phe level, which resulted very high. So his initial plasma Phe level was 1,380 micromoles per liter, so well above goal. And we then completed phenylalanine hydroxylase sequencing, which resulted in a confirmed homozygous mutation for PKU, with these variants classified as common and severe variants. So of course, we brought the boy in for an initial visit with our metabolic team, and we conducted an initial nutrition assessment. So his anthropometrics were relatively unremarkable. His mother reported he is on a completely unrestricted diet, and he does eat foods that are high in intact protein, like meat, eggs, fish, but she did mention that he kind of self-restricts portions of those types of foods. Overall, his diet was really rich in things like whole grains, dairy, vegetables, fruits, and beans. You can see on this slide his estimated nutrient needs based off of his age, his classic PKU, and his anthropometrics. So it goes without saying that this case came with several challenges. First of all, he was accustomed to a diet high in intact protein, right? He had also never tried a protein substitute before. And we knew his genetic variants were classified as not responsive to tetrahydrobiopterin therapy. So we knew he was going to need a pretty restricted diet to achieve some sense of metabolic control. So due to these challenges, we decided to take some really practical first steps. So first, we just started with a reduction of intact protein intake by recommending he go on a vegan, gluten-free diet. diet, okay? This was just our attempt to initially dramatically decrease his intact protein intake without over-restricting, since he was not yet on any protein substitute reliably and had never followed a super restricted diet. We then provided a trial of a variety of protein substitutes, including those based in GMP. And we came up with a reasonable Phe level to aim for of less than 600 micromoles per liter. You can see on the table where we started with the Phe of 1,380 micromoles per liter on diagnosis. And then just within 10 days following the vegan and gluten-free diet and starting to trial those protein substitutes, we already saw a decrease in his plasma Phe level by about 450 points. So really cool. So next steps were then to optimize his plan. So while his plasma Phe level had decreased, it was still well above a goal that we were comfortable with. So we knew we had more work to do. His mother reported that he was following this vegan and gluten-free diet, and while it was challenging, it was pretty manageable for him, so that was really great news. The family was really wonderful and able to provide a 3-day diet record that we could analyze. And then we went ahead and reviewed how his trial of protein substitutes was going. So the family reported that he had a really strong preference for the GMP protein substitutes over the amino acid protein substitutes, and that really reliably he was taking about 15 grams of a GMP protein substitute, 15 grams of protein equivalents, that is, every day, mostly at breakfast. So for our next steps, we really wanted to optimize his plan. So we first provided education on the simplified diet and implemented a goal of counting 16 to 18 grams of counted protein per day. We went over the uncounted foods, the counted foods, and we came up with this goal of the 16 to 18 grams of counted protein based off the 3-day diet analysis that we completed from the family's diet records that they provided. We then discussed aiming for 30 grams of protein equivalents per day coming from a GMP protein substitute. And we really wanted to optimize this as well. So we discussed offering the protein equivalents from the GMP protein substitute throughout the day, so spread out 10 grams at breakfast, lunch, and dinner. We also gave some helpful tips like providing almond or coconut milk or even just water after the delivery of the GMP protein substitute. And then we, of course, let the family know if he's willing to take additional GMP protein substitute throughout the day, we would count that as bonus points. So we can see really clearly here the impact of the nutrition interventions, and I just want to walk you through this journey briefly. Here, this red star is where we started with that initial plasma Phe on diagnosis. Of course, it's very high. This green star then shows that decrease in plasma Phe levels as we really started that transition onto the simplified diet, and we were working towards increasing to that 30 grams of protein equivalents daily from the GMP protein substitute. We then had a pretty good run with some stable Phe levels as we continued to work on this diet and protein substitute intake. But of course, we hit a few roadblocks. So at this red star, he got sick, so his plasma Phe levels went up. We were able to kind of recover from that. And then again, plasma Phe levels went up when he actually ran out of his GMP protein substitute. So he was off protein substitute for a minute. And then again, once we really started continuing to work on this transition, you can see that his plasma Phe levels came down into target range for him. So right here at this yellow star, less than 600 micromoles per liter. And this is him when we analyzed the 3-day diet record that went along with that plasma Phe level in goal, where he is on that 30 grams of GMP protein substitute a day, and then the simplified diet. So now to wrap up, where are we with this case? So unfortunately, he hasn't had any changes in behavior, but his hair has darkened, his skin tans more easily, his eczema is still present, but very much improved. We've decided as a metabolic team to start him on a trial of tetrahydrobiopterin soon. We know that he's not likely to be a full responder due to his classic PKU, but we feel it may help with some Phe level stability or even increase his Phe tolerance from diet slightly. So we do feel like it's going to be worthwhile to at least do a trial. And really, in summary, the GMP protein substitutes were a total game changer for this patient. He was really uninterested and unwilling to take the amino acid-based protein substitutes. And so his willingness and acceptability of taking the GMP protein substitutes has made a huge impact in his treatment plan and outcomes for his late diagnosed PKU. Included here are my references. And now I'm going to go ahead and turn it over to Anita.
Thank you, Chanel. I am happy to now introduce you to our second speaker, Professor Anita McDonald. Anita McDonald is a consultant dietitian in inherited metabolic disease at Birmingham Children's Hospital in the UK, and an honorary professor in dietetics at Plymouth University. She has a wealth of experience in pediatric dietetics, having worked as a clinical dietetics specialist for 40 years. She is a fellow of the Royal College of Pediatrics and Child Health, and her involvement in aspects of inherited metabolic disease has spanned most of her working life. Professor McDonald obtained her PhD in phenylketonuria in 1999 and is actively involved in all aspects of inherited metabolic disease research and development in this discipline. She has extensive research experience with more than 400 publications and has lectured in more than 30 countries on topics relating to nutrition. I'll now pass to Anita, who will continue the presentation with some interesting case studies.
Well, ladies and gentlemen, thank you very much. Today, I'm going to present 3 case studies of young children who had glycomacropeptide, and I'm going to tell you about their outcome. The first is a little boy. He's of Eastern European origin. He was born at 39 weeks gestation. His mother's pregnancy had been complicated by obstetric cholestasis. She'd experienced a number of early pregnancy losses. So this was her first child, and it was obviously very, very precious. And he was born during the COVID pandemic. And then he was identified by newborn screening to have PKU. He was born in the UK. His blood phenylalanine level on confirmation on day 12 was over 2,500. We screen on day 5 in the UK. His mutations confirmed that he got classical PKU. His weight and head circumference was on the 5th percentile, where he was quite a long baby. He was on the 50th percentile, and at the time of presentation, he was breastfeeding. So on the start of treatment, he continued with breastfeeds, but we gave him phenylalanine-free infant amino acid formula before every breastfeed. He continued to breastfeed up until the age of 9 months. He started weaning just slightly prior to 6 months of age. We have a very standard 3-step process with the way that we wean our babies with PKU. We start them with low protein solids. We gradually introduce spoonable protein substitute, and at the same time reduce the volume of the phenylalanine-free infant formula. And then we gradually introduce phenylalanine exchanges. And certainly by the time this little man had reached 1 year old, he was taking 3 phenylalanine exchanges, which was equivalent to 150 milligrams of phenylalanine per day, or around about 3 grams of natural protein. He stopped taking the Phe-free amino acid formula around about 19 months of age. Now, when this little man was 18 months of age, everything was going fairly well from the PKU point of view. He had almost 90% of his blood phenylalanine levels within target range. By this stage, he'd increased his phenylalanine tolerance a little. He was tolerating 200 milligrams of phenylalanine per day. We was giving him a total of 3 grams of protein per kilo per day, both from his natural protein and from his protein substitute. He took spoonable protein substitute 3 times a day. He took 30 grams of protein equivalent from this. Took around 10 minutes to administer each dose, and he was still taking 1 to 2 bottles of the fee-free infant amino acid formula each day. So things was going fairly well. And in fact, things were fine until his mum was pregnant again. And obviously it was good news for the family, but the problem was that mum suffered severe nausea every time she tried to make up the spoonable amino acid protein substitute. And this was a problem with the mum with every pregnancy. The previous pregnancy, she struggled with the smell of dishwasher solution, and for a new pregnancy, it was the smell of amino acid formula. Now, fortunately, when mum started with problems with nausea, the grandma was over from Eastern Europe. We had access to her for something like 3 weeks. So she continued to administer the spoonable protein substitute. But we had 3 weeks to find a solution. So we tried the little boy on all the other suitable amino acid protein substitutes for his age. But unfortunately, none of these were any good. Either the little boy didn't like them, or they made the mum feel very sick or made her vomit. So we were struggling, and it was almost time for the grandma to return to Eastern Europe. So the only thing left for us to try was glycomacropeptide. And to our relief, the smell of glycomacropeptide didn't make mum feel sick, and the little boy actually liked it. Now, we was quite concerned at this time because this boy had classical PKU. We were concerned about the phenylalanine content of GMP. And what we decided to do was give 2 doses of his protein substitute as GMP. We gave him 2 doses of 10 grams of protein equivalent each. And the remaining 3rd dose, we just decided to add it to his infant feeding bottle of the infant protein substitute. This way the mum wouldn't have to smell it, not an ideal way, but she wouldn't have to smell it. By giving him 2 doses of protein equivalent from the GMP, it provided 36 milligrams of phenylalanine, and we reduced his phenylalanine intake from his diet by 25 milligrams. So we was giving him 175 milligrams of phenylalanine per day. We administered the GMP in a drink in a 90 ml format, and the little boy took this quite quickly. Now, the next problem we had, because the little boy took the GMP very quickly, he then refused to take his infant formula with the added spoonable protein substitute. So we had no choice but to put him up to 3 doses of GMP and make the necessary changes to the phenylalanine intake in the diet. So what was the nutritional composition of the GMP that we was given to this boy? What did it provide him in his diet? Well, with 3 doses per day of 10 grams of protein equivalent in each dose, it provided 20% of his energy intake, just over a quarter of his phenylalanine intake, fairly generous amounts of calcium, iron, zinc, and selenium, between 150 to just over 200%, but this wasn't excessive. It just met his vitamin D requirements and vitamin A requirements, provided reasonable amounts of vitamin C and thiamine, and plenty of folic acid. And how does this compare with the spoonable protein substitute? So what I've got on this slide is the percentage of the dietary reference value provided by the GMP and the percentage of dietary reference value provided by the amino acid solution, by the spoonable amino acids. And what we find was that the spoonable amino acids would have provided around about 28% of its energy intake, so a little bit more than the GMP, absolutely no phenylalanine. It would have provided just over 200% of the calcium intake, a little bit more than the GMP, but very equivalent. Fairly similar amounts of iron and zinc and selenium. The spoonable protein substitute would have supplied more vitamin D, a little bit more vitamin A, more vitamin C, and thiamine and folic acid, not so dissimilar. So what was the blood phenylalanine results of this little boy? So on this slide, I've got the blood phenylalanine levels when he was taking the amino acid preparation and when he was taking the glycomacropeptide. So on the y-axis, we have the blood phenylalanine concentrations. On the x-axis, we have the little boy's age. And basically anything above, any results, any dots above the red line means he had high blood phenylalanine concentrations. And you can see when he was on the amino acid preparation, yes, we did have some occasional peaks in blood phenylalanine level, and this was associated with illness. When he went on to the GMP, we have the odd levels that was greater than 360 micromoles per litre, but on the whole, he's been fairly well controlled. As far as his length and weight is concerned, this little boy has continued to grow very well on the GMP and has continued to gain weight well, but not excessively on the GMP. Now, he's now been on GMP for something like 6 months. What about his blood phenylalanine concentrations overall? We're achieving about 81% of his blood phenylalanine levels within target. So a slight loss of control, but equally it's still very good and very acceptable. His growth centiles have been maintained. Since he's been on GMP, we have tried to test him with sapropterin, but not surprisingly, he wasn't a responder to this. But generally, we've got a very happy little boy now. He actually enjoys and asks to take his protein substitute. He takes it very quickly. He's certainly hungrier than he was before. And it's taken away some of the tension from giving the protein substitute within the family. So we do have a happier family and do not find giving the protein substitute now quite so burdensome. So that's the first case study. But now I move on to my second case study, and this is a very different story. This is a little girl of nearly 4 years, Pakistani origin, lives in the UK and born in the UK. It's quite a busy household. She's got 2 older siblings, a brother and a sister, and 1 younger little brother. So very, very busy. She was identified by newborn screening. Again, she had a diagnostic blood phenylalanine level of over 2,500, and not surprisingly, her mutations showed that she got classical PKU. She was weaned at about 4 months in the same way as the first case study. She was given a spoonable protein substitute at 6 months, and she stopped taking the phenylalanine-free infant formula at around about 2 years. Now, although this little girl took the spoonable protein substitute okay, it always took round about 10 to 15 minutes to give each dose. And when this little girl was 3, she was taking 15 grams of protein equivalent 3 times a day from her spoonable protein substitute. And we'd always discussed with the mum that we would start to change this little one over to a liquid amino acid pouch round about 3 years of age. And mum was anxious to do this. She wanted to change her over. She wanted things to be a little bit easier. When we normally change children's protein substitute over, we do this quite slowly. We follow a systematic transition plan. And this is what we did in this case. But by the end of the first week, this little girl was taking her liquid protein substitute really very well. Mum was very pleased. And what she did, she changed over all the protein equivalent to the new liquid protein substitute instead of the spoonable protein substitute, basically in one go. And then what happened, progress was short-lived. It was all a little bit too much too soon. And the little girl started spitting out the liquid protein substitute. It was taking 1 hour to give every single dose. Her blood phenylalanine control really deteriorated. The little one, probably because of the higher phenylalanine levels, became that little bit more difficult, a bit more stubborn. She didn't want to engage. She would run off somewhere every time a protein substitute was due. And generally, because it was a busy household, there was lots of people involved in giving the protein substitute. The grandma was involved, daddy was involved, mummy was involved, and they all had a slightly different strategy in the way that they gave the protein substitute. But basically, things weren't going very well. Obviously, we was talking to the family throughout this period and trying to find a solution. So we did discuss the possible option of glycomacropeptide. This little girl only tolerated 4 50 milligram phenylalanine exchanges, around about 200 milligrams of phenylalanine a day prior to GMP, or 4 grams of natural protein. Mum was a little bit reluctant to reduce the exchanges at this time, but agreed to give GMP a go. We got really nothing to lose because we were struggling to give the protein substitute. What we tried to do was give 2 doses of GMP. We gave 15 grams of protein equivalent each dose. And the third dose, we continued to try and give an amino acid, phenylalanine-free amino acid supplement. We took into account the phenylalanine from the GMP. This provided just over 50 milligrams of phenylalanine per day from 2 doses, and we reduced the little girl by 1 phenylalanine exchange. Now, interestingly, the little girl really liked the GMP, and she took this. She was taking each dose within 10 minutes, but it actually made it much tougher to give the phenylalanine-free amino acid supplement. She really was refusing point blank. So that we had the option of going on to 3 doses of GMP, or basically going back to square one, to the spoonable protein substitute. We talked this through with the mum. She really didn't want to reduce the phenylalanine intake anymore. This was really quite important to this little girl. So she asked if she could stop the GMP and return to the spoonable amino acid supplement. I am pleased to report that now this little girl is back on the spoonable protein substitute. She's taking it better than she's ever taken before. Her blood phenylalanine control has improved again. She's due to start school in September, and we will start again the transition process. And with a little bit more maturity with the little girl, I'm sure we'll get there next time round. But for us, for this little girl, the phenylalanine content was a bit of a problem. Then we come to the final case study, and again, a different child altogether. This is a 5-year-old girl now. She was diagnosed in Romania with PKU. She was picked up at the age of 30 days. Again, her PKU mutations show that she's got classical PKU. She's an only child. She came to the UK when she was 2.5 years old. She's quite a tall girl. She's on the 95th percentile. She's on the 75th percentile for her weight, and she's not responsive to sapropterin. When she came to the UK at the age of 2.5 years, she was taking a powdered amino acid supplement that she made up into a drink with a small amount of water. This provided a relatively small amount of protein equivalent, 1.1 grams of protein per kilo. She was given this protein substitute 4 times daily via a cup and spoon. It was taking about 10 to 20 minutes to give each dose. When she came to us, she tolerated 300 milligrams a day of phenylalanine, and this was taking into account all the phenylalanine from all the foods, including fruit and vegetables. And she monitored her blood phenylalanine levels once every 2 weeks. So when she came to us, we did a few adjustments with her diet. We hadn't got the same amino acid supplement that she was using in Romania available to us in the UK, but we found something very similar. And to try and maintain that little bit of consistency until we got to know this little girl, we made up the amino acid powder very much in the same way, to the same volume of water as before, 80 mils. We did give her a little bit more protein equivalent from protein substitute. We increased this to 2.2 grams of protein per kilo, a little bit more in line with our UK standards. We continued to give the protein substitute 4 times a day because this is what the little girl was used to. It continued to take 10 to 20 minutes to give each dose, and Mum still gave it in a cup and spoon. We adjusted the phenylalanine allowance only because we don't take the phenylalanine content into fruit and veg into account, so we cut this down to 200 milligrams per day, and we increased the monitoring to weekly. Now, at the age of 4, this little girl went into school. And within the school setting, we asked the school to give 1 dose of this amino acid supplement each day. And this meant the little girl had 3 doses of protein substitute to take at home, 1 dose in the morning, 2 at night. But because this little one was so exhausted going to school for the first time, she was still very little, she was often falling asleep before the final dose. So this wasn't working. We then asked the school to give 2 doses of protein substitute at school, but the teachers weren't particularly happy with us. They had to spoon feed it to the little one. It was taking around 20 minutes to give each dose within the school, and it was meant that this little one was having to miss some time out of her lessons, and that was causing a problem. So we had to take stock and readjust what we was doing with the protein substitute. So we talked about the possibility of using GMP with this family. This little one had never taken the amino acid supplement particularly quickly. We tried the little one with 2 or 3 doses of the GMP, and to our surprise, she took it incredibly well. And Mum was keen to replace all the protein substitute with the GMP. We gave her 3 doses of GMP a day instead of 4. There was 15 grams of protein equivalent in each dose. We provided 2.2 grams of protein equivalent per kilo. She was taking less than 5 minutes to take each dose of protein substitute, which she gave as a little drink. We did take the phenylalanine into account when we gave the GMP. This was providing, in fact, just over 80 milligrams of phenylalanine per day, but we just deducted 50 milligrams from a daily allowance. But this was fine for this little girl. She coped with this very well, and we continued with weekly monitoring. Now, what has actually happened? The girl continues to take 1 dose of protein substitute now in school only instead of 2. And the little one is very independent of taking a protein substitute in the school. The teachers are very happy with her and say it's gone within a couple of minutes, and everybody's pleased with this. There's certainly less family tension surrounding the protein substitute administration. It's no big deal anymore. Taken very quickly. Her appetite has improved, and her mum is an absolutely wonderful cook, so this is very important to the family. She's eating many more low protein foods, and her growth is as expected. If we look at the blood phenylalanine control of this little girl, on the y-axis we have the blood phenylalanine levels, and on the x-axis we have her age. And in between the orange lines, this is the blood feed targets that we're aiming to achieve. And prior to the blue line, this is when the little girl was on the amino acid protein substitute. And you can see from time to time, we did have higher blood phenylalanine levels, but this was generally associated with illness. Since she's been on the GMP, as you can see, she's had pretty good blood phenylalanine control, and any higher levels that we've had have just been associated with viral infections, but she's done pretty well and we're very happy with that control. So all in all, this little girl hasn't looked back since she's been on the GMP. So what I've shown you today is a selection of case studies of young children with PKU who've had glycomacropeptide. 2 of these cases have been very successful, one not so successful, not because she wouldn't take it, but the phenylalanine content of the GMP was a problem. Certainly what we saw in these 3 younger children with PKU, giving them the GMP was an all or nothing event. We couldn't just give them 2 out of 3 doses of protein substitute as GMP. Once they got used to the taste of it, they didn't want to take amino acid supplement at all. So this was something that we had to take into account. We also felt it was important because all these 3 children had classical PKU that we got no option but to take the phenylalanine content of GMP into consideration into the calculations of the daily phenylalanine allowance. In the 2 successful cases where we was able to give the GMP, what we did see was that the administration of the protein substitute was associated with less burden to the family. The children took it very easily and the appetites of the children improved. And this is something that is definitely worth further study. We can't say that the GMP increased the satiety. It was the reverse. They was enjoying eating the food much more, which I think is much more valuable for the children. But what we need in the future is age-specific GMP protein substitutes for our young children that specifically designed nutritionally and hopefully with a lower phenylalanine content. Thank you.
Given time, we'll have time for just a couple quick questions. And I just wanted to remind folks that you can certainly pose a quick question to the group by typing in a question in the question pane. The first question we have is related for Anita. If you wanted to start,
Yes.
Are there other features besides taste that may drive parents' decision for a GMP product?
Okay.
In your experience?
Yeah, it's. I think when taste is clearly a big thing, and it's usually driven by that. Certainly in terms of the other potential positives associated with GMP, such as better gut function, less constipation, it's a possibility. We're not out there with the evidence yet, though, Chanel, are we? And so we can suggest that things are better, but we can't categorically say things are better. I think that the breath and the smell on the breath is a real big thing for families. They think that is so much better. In terms of appetite and satiety, you can see that those children ate better once they went on to the GMP. So I'm not convinced about any of the satiety argument with GMP whatsoever. As far as we do talk a lot about growth, and I do believe there is something in the growth in the GMP, but the story's not out there that children may achieve their potential that little bit more with GMP, but we need more evidence. The bone, we can't say too much about because we haven't proven the bone concept at this moment in time. So the parents are very interested in the fact they perceive this to be a more natural product. Clearly they do, but I think number one factor that drives it is taste, and that it's easy to administer, and it's easy for the kids to take, and it's less burdensome for the families itself. That that it's minimal mixing as far as it's a powder. It needs mixing, but it's relatively easy. So I think we need much more evidence on all the other benefits yet for for GMP before we can jump up and down too much with families, and we need to be always honest about it, and this is why I'm always so straight about the phenylalanine content as well. But I've been quite impressed so far with how well the little ones have taken it. That's good news. We need more data, we need studies, we need products for the little ones, and let's see where this journey goes.
Chanel, did you want to add anything?
No, I think Anita summed that up perfectly. Thank you.
Great, thank you. Just wanted to ask another question. In terms of your case study, Chanel, were there any challenges with maintaining adequate caloric intake during the dietary and nutritional interventions and transitions?
Yeah, that's a really good question. I do have to say this family really loves to spend time in the kitchen. And so this mother in particular was very dedicated to creating foods and recipes for her son that were low in protein, but really nutritionally dense. But what I will say is I was definitely concerned about caloric intake given this kind of big shift with his new diet. We did, and I didn't mention this in my slides, we did offer him and order him a lot of the low protein specialty foods to give him a lot more options. So a lot of the low protein pastas and breads that tend to be a little bit more calorically dense, because he does have a preference for those style of foods. So we definitely worked with the family on getting the low protein specialty foods to ensure caloric adequacy. Like I said, the mother was very interested in cooking and creating meals for him, but we really emphasized a lot of additions of healthy fats to foods to ensure that caloric adequacy and kind of nutritional completeness as well. So that's how we worked around that for this case.
Great. And Anita, pertaining to the first case study that you presented, did that first child end up on a combination of GMP and amino acid-based protein substitutes?
No, we tried to. So the first week or so, we tried to give him 2 doses of GMP, 1 dose of amino acid hidden in a baby bottle, which went against my again beliefs. But we was really trying to minimize impact on phenylalanine intake as much as we possibly could, but the little boy wasn't having any of it, and that's the thing about these little ones. Once they get used to the taste of GMP, they don't want to go back. And so I think the studies that we've done in older children, where you can negotiate with the older children and end up with 2 doses of GMP, 1 dose of amino acid, you can get that to work. But with the little ones, try negotiating with any 2-year-old. And so it was basically we had to go through 3 doses of GMP or basically end up short of protein substitute. And so we got the concerns on phenylalanine intake, but again, that was seen from the family point of view to the loss of phenylalanine was far too was far outweighed by having a child who actually wanted to take the protein substitute and actually wanted more of the protein substitute and liked the taste and liked his little milkshake and liked every flavour. So that was actually good to see that somebody's actually looking forward to it. And it was the protein substitute was such a big thing in that household. And so everybody was much happier. And the mummy, because of the problems she'd had with protein substitute and the problems she'd had with the pregnancies, and PKU was a huge thing, and then having a child who they was getting the spoonable protein substitute into him, but it was 20 minutes 3 times a day. It just seemed quite a big burden, and having a little boy who didn't particularly want to take it, and it was almost fortuitous she got pregnant and couldn't cope with the smell of it. But actually everybody's much happier in the household, so that is lovely to see. And it was worth just saying, let's go with this 18-month-old and trying it and seeing that, and we're managing the control. I can't say we haven't lost a little bit of control, because we have just a little bit, but we're holding it. We're holding it, and so we're happy with that.
Okay, thank you. And certainly acknowledging both of your comments related to the need for further evidence. I just wanted to end on one final question, kind of posing to both of you. Based on your clinical experiences, do you tend to now use GMP protein substitutes in children only when there's challenging cases, or has things kind of changed or opened up for you? Chanel, if you want to start also.
Sure, I can go ahead and go first. No, I certainly don't only utilize it in challenging cases. I think that, to your point, as we know, more and more research is needed, but I think some of the evidence and the research that we have now is really a wonderful starting point, and there surely are some potential benefits of utilizing GMP, and I like to offer it early on in a lot of my younger children and younger patients as another option, like proactive, versus only utilizing it when there's a challenge and plugging it in. So I certainly offer it and utilize it much earlier. Yes.
A challenging case in a challenging case. What we have found in the last year, we've gone from nothing to about 6 cases now of little ones taking the GMP. And I think instead of it being really, we are up against the wall completely with no other option, as soon as we hit a few difficulties, we'd be inclined to try GMP rather than it being the end of the road approach to do it. So it's still not first line with patients with classical PKU. We've got a little bit of a way to go there. But if we hit that obstacle, that roadblock, as Chanel said, if we hit that roadblock, then it's an option we would consider that little bit earlier than we would have done before. As we're building up the experience, it's important that we write up the case studies, we write up the issues, that we're open and honest about all the issues, so that we can evaluate it properly. But it's coming. It's definitely coming.
Yeah.
But we want more products. We want more products. That's important. Because nutritionally, the products are actually designed for older patients. So it's important that we have products that are designed for the younger children, that have got a good amount of vitamin D, a good amount of vitamin A, and we're not worrying about having to consider supplementation. We can cover some of this with good diet, but we need something that completely nutritionally matches. So we've just, we need a little bit more yet for that age group, but we're moving in the right direction.
Of course. Well, thank you. Thank you to you both. And I think that is all the time we have today for questions. And I wanted to thank you, Anita and Chanel, again.
No, thank you very much.
Thank you for taking the time to attend today's webinar. We hope that it has been helpful to your practice. Please complete the feedback form, which will be in the post-webinar email you will receive. Included in the feedback form, you will see the same 3 questions you answered after you registered for this webinar. Please consider answering those questions too. I'll be sharing the collated results of those questions via email to attendees. The next PKU-related webinar hosted by VitaFlow will be held on the 18th of July and is titled PKU and Aging. Make sure to tune in. On behalf of VitaFlow, thank you to our speakers and to you, the audience, for joining us today. Goodbye and enjoy the rest of your day.